is Jess. It's an honor to introduce our speaker, Jess, qualified as a midwife in 2020, driven by strong passions for supporting vulnerable women and families. Currently completed a Master of Research at Bournemouth University, funded by the National Institute of Health and Care Research. Alongside her academic work, she's continued to practice as a safeguarding midwife at University Hospital Dorset and contributes of the Wessex Women's and Girls Research and Innovations Network. Hi, Jess.
Hi, Khadija. Thank you.
How you doing?
I'm fine, thank you. I'm looking forward
Thank
to
you.
this.
Now the mic is yours.
Thank you. Oh,
You're welcome.
we might have a slight issue.
Just zoom out.
Okay. Sorry, everybody.
You can restart. You can restart your share or just sharing from myself. Yes.
Let's try it that way. Hi everyone, my name is Jess, and as Khadija said, I'm a safeguarding midwife, currently working at University Hospitals Dorset here in the UK. And I'm here today to talk to you about the literature review that I've completed as part of my research, exploring how women make decisions around prescribed psychiatric medication use in pregnancy. So I thought it'd be nice to start with a little bit about me. Let me get to the right.
Jess, can I share with myself and you can just
Yes, please.
say,
Let me
okay?
share.
Okay.
Technology always likes to give us
Yes,
some problems.
okay. Don't worry, it's okay. It's happening. It's good for you?
The
It's
next
visible?
slide. Yeah.
Okay. Okay, let me.
Next one. Lovely. So, as Khadija said, I graduated as a midwife in 2020 from Bournemouth University, and I've always had a really deep rooted passion for supporting vulnerable women, something which kind of came from my own lived experience, having my first son when I was 18. And I felt like I couldn't even make decisions for myself, let alone now being expected to make decisions that impacted my unborn baby. I was so lucky to have an amazing midwife care for me who helped me to understand the choices that were available to me. And it meant that I felt informed and empowered to be an active part of my maternity journey. And this is something that I really aspire with my own practice. It's really about ensuring that all women and birthing people feel they're making informed choices regarding their maternity care and receive care that is holistic and tailored to their individual needs. So, after having that most amazing care that I had, I took a job working in the very team who cared for me as a vulnerable young mum. And I'm extremely proud to work there as a specialist safeguarding midwife. And I juggle my work life alongside having 4 boys of my own and now my research study, which I'm really excited to share with you today. Throughout my time as a safeguarding midwife, I've supported a number of women who have struggled with their mental health throughout all stages of their pregnancy and postpartum journey. And what I noticed was I was having the same repeated conversations with women when it came to their mental health treatment plans. They were stopping medication with no alternative support in place during a time when they were most vulnerable. Next slide, please. So to give you a little bit of background to the study, Wembley Stadium, some of you might find this quite a familiar image. It has a seating capacity of about 90,000 people. 6.6 times the capacity of this stadium represents the average number of births in the UK. So it's about 600,000 births. 1.6 times the capacity represents the number of women on average who will struggle with poor mental health during their pregnancy or the postpartum period. It's roughly about 150,000 women every year in the UK. Unfortunately, the most up-to-date statistic I could find was from 2018, but that found that 13.4% of all pregnancies had a prescription for some form of antidepressant medication during their pregnancy. It's just over 80,000 people, roughly the capacity of Wembley Stadium. And when we consider that suicide is the leading cause of maternal death in the 6 weeks to 1 year post-birth, we can really start to understand the scale of the problem. Next slide, please. So, thanks to advancements in modern day technology, women are able to confirm pregnancy sometimes as early as 3 to 4 weeks gestation. That's so early. And when we think about our NICE guidance, women aren't actually routinely seeing a midwife till about 8 to 10 weeks into their pregnancy. So, if a woman has a pre-existing mental health condition, who's going to counsel that woman around her medication? Who gives her the information she needs to be able to make an informed choice? Because when you pick up that packet, you've been stable on those medications, maybe for many years, and it now says not recommended for pregnancy. How do you make that decision? Who do you go and speak to get that advice? So, unless under the care of secondary services such as the community mental health team, most commonly women will seek advice from their GP. But sadly, GPs tend to report a low confidence in counselling women around mental health medication use in pregnancy. And in practice, what we actually see is women routinely being told to stop medication due to the risk posed to their unborn baby. And that's without considering the risk that abruptly stopping medication can have in terms of the risk of relapse or providing any alternative treatments or support. So again, if we think about that woman who's maybe been stable on medication for a long, long time, it's kept her well, it's kept her able to cope with the day-to-day of life, now faces the reality of stopping that medication. How does she navigate that? How is she going to cope with things without that medication that's kept her well? And that in itself can be quite anxiety inducing and worrying for a woman. And now you're going to take away the one thing that she's felt that's kept her stable. And with GPs not giving any alternatives to medication, what does that look like for that woman? Next slide, please. So I started to reflect on my clinical experiences and interactions with women. And I personally felt really frustrated for the women in my care who were telling me that fear was a determining factor for their decision. Women talked about the fear of harming their baby, the responsibility of keeping their baby safe, and the thought of self-blame if something was to happen to their baby. And once we plant the idea of harm to a baby, it's almost impossible to change that narrative. How do you then reframe that discussion and balance that risk around actually the impact of not being stable on your mental health medication and being unwell compared to what the women are seeing as their risk to their baby? It's that choice between my baby or myself, and that's how women very much saw it. And as women and as a mother myself, you would do anything to protect your baby and want to keep your baby well. And that's how these decisions were being framed to women. I knew as a practitioner I wanted to be able to counsel women properly around this decision. And so these conversations with women were very much the inspiration behind my research project. And I was lucky enough to be awarded a funded Masters by Research through the National Institute for Health and Care Research, and have a fantastic team of equally passionate supervisors to support me along the way. I wrote my clinical experiences up as a reflective piece, which was published in the March edition of the Practicing Midwife, and very much use these clinical experiences as a basis for my research study. So how was I going to make things better? How could I change the way these women were feeling? How could I ensure that they felt informed and supported so they weren't making decisions out of fear, but out of informed choice? Next slide, please. I decided I really needed to understand, how do women make decisions around prescribed psychiatric medication in pregnancy. Next slide. So I started with a systematic search of the literature, looking at multiple different databases, focusing on qualitative research that looks specifically at women's decisions. In total, I found 38 papers across the databases, but only 5 of those met the requirements for inclusion in the review. These 5 papers came from various countries. They were recent within the last 10 years, and that was really to reflect current influences, so things like media, social media, news articles, and pressures on healthcare services. I wasn't surprised to find a lack of research, but I was surprised to find that the majority of the research available focused on the views of professionals prescribing medication to pregnant women and not the views of those taking the medication. As healthcare professionals, we can make care plans, we can suggest treatments, and we can recommend medication, but we can't make somebody take the medication or follow the treatment plan. So the views of women or patients in general when considering treatment plans are crucial to understanding compliance and ensuring appropriate personalised care. Next slide. So what did I find? Ultimately, I found that these decisions are not straightforward. They are complex, multifaceted, and highly individualized. I completed a thematic analysis and was able to establish 5 themes within that. And they were shared decision making, access to support, healthcare professional, acceptance and validation, and then experiential evidence. And that was both personal experience and third-party experience. And those themes were really clear themes across the studies. They weren't themes that there was small pieces of research. They were really clear themes, and you could see how they linked together. And when they started to kind of piece together, I was like, yeah, this is really making sense. Next slide. So when we talked about shared decision making, it's really understanding that shared decision making was about that collaborative process where clinicians and women work together to reach decisions that reflect both clinical knowledge and personal values. There isn't a hard and fast rule when it comes to prescribed psychiatric medication in pregnancy. And so often women would describe decision making more like taking a punt, a gamble, and trusting gut feelings, rather than there being kind of that clinical decision making or stats to back these decisions up. It showed that women have an awareness of risk, but it was determining the safest decision for both them and their baby, which they found most difficult. And there were various strategies that were talked about across the different studies that were used to kind of balance risk. So some studies talked about opting for established medications at the lowest dose, and that was almost seen as kind of a common sense approach, compared to some women talking about reaching a tipping point where it was felt medication was basically the only option. And what the studies demonstrate was that perception of risk is individual to each woman and impacted very much by their current situation, past experiences, and their moral responsibility as a mother. Yet the literature tends to present these decisions descriptively, and it doesn't explore how healthcare professionals engage women with those decisions and navigate that interplay between the uncertainty of the decision that they're facing, the moral conflict as a mother, and the social pressures of society that's impacting that decision. So that was a really key theme throughout the research, of actually women wanting to be active participants in their maternity journey and feeling that that decision was something that they should be making in partnership with the clinical professionals involved with their care. And when I reflect on that these findings now and looking at our services now, it's almost that women have to be, and in general, we have to almost be a bit of an expert in our own care. Those people that are in the UK may be familiar with the NHS app, and you can request information, like give the GP your information and tell them what you think the problem is, and then it will ask you, what do you want from this? And it's almost like there's that expectation that you need to be an expert in your own care and what you need and what you want from a service. And that's becoming quite the norm with healthcare. And I think women are bringing that experience from their healthcare to their maternity services, and want to be more informed and active participants in their care. Next slide. So looking at access to support, globally, those approaches to prescribed psychiatric medication use in pregnancy vary significantly. And that really reflects the difference in healthcare structures and cultural assumptions about risk and responsibility. While some found that access to support was limited by referral processes, fixed criteria, and extensive wait times, others discuss the benefits of having open access with specialist professionals, creating safety plans in partnership with women and having their partners there as well, because partners were then aware of how to recognise symptoms of relapse and how to access treatment or support. And these findings really suggest that healthcare systems which promote accessibility and partnership strengthen women's agency and reduce that burden of moral conflict, whereas restrictive systems inadvertently intensify mistrust, and they almost reinforce women to rely on informal or potentially unreliable sources of information. If you can't access it easily, you're going to access information that is easy. So you are going to look online, social media, Facebook groups, and those things aren't necessarily the most reliable sources of information. But if you can't access a health professional, where else do you go? Next slide. So while the role of healthcare professionals in delivering evidence-based information is really clear, how effective they are is underpinned by the level of trust women place in their professional. And this extends beyond professional expertise. It encompasses the quality of the relationship, the empathy, having meaningful conversations. We know this is not a new concept within maternity services. We've long championed continuity to improve fetal and maternal outcomes, often referring to this relationship as the midwife-mother relationship. And it's this bond that fosters the trust and understanding and supports that shared decision-making. And these two themes were really closely interconnected, that healthcare professional and shared decision making, who that health professional was, who was giving you that information, how much trust do you place in them, have you had poor experience with them before, are they just signposting you to information, or are they confident in the information that they're giving you, and are they able to back that up with facts and statistics, or are they just kind of a bit wishy-washy and not really clear on the information? And that was really important within the research. Next slide. So acceptance and validation was a really key theme as well. And when we talk about acceptance and validation, this is thinking about society's expectations, the role of partners or important people within the woman's life and their views, but also validation from professionals that the decision that they're making is the right one for them. There's an expectation that pregnancy is always a joyful event in a woman's life, and this really undermines the complexities and lived experiences of those navigating mental illness alongside pregnancy. While physical illness is widely accepted as almost a legitimate need for medication, the hidden and often stigmatized nature of mental health conditions positions psychiatric medication as almost morally questionable. Women almost could justify the need for medication if there was something that people could physically see. Oh, you are physically in pain, or you've you've got some sort of physical condition that we can see. So that means that medication is socially acceptable, but people can't see the impact of mental health, but they just see the risk that that medication poses to a baby. And so that means that it's almost less accepted by society. Across the studies, there was reference to the importance of partner support and the view that the unborn is a shared responsibility, and therefore that decision for or against medication lies with both parents. And this was really interesting to read in the research, because this wasn't so much something that I'd seen clinically in practice. I didn't really see partners feeling that they had a right um, to influence the decision of women, but actually my experience was partners being quite supportive of that being the woman's choice. So seeing that seeing that being quite different in the literature review was interesting. But it also talked about the importance of partners being present during appointments, and it was almost seen as crucial to support decision making, because it was difficult in defending decisions in their absence. So where partners maybe had a differing view, they almost felt that women almost felt that they had to defend their decisions because the partner wasn't there to hear the healthcare professionals say, yeah, that seems like a sensible decision. And it demonstrates again how decisions are not solely clinically based, but influenced by that relational trust, but this time within intimate partnerships, so family, friends, society. Next slide. So then we move on to experiential evidence. And as I said, this is really about the difference between lived experience and seeing that experience third party. Women's personal perceptions of their ability to cope played a real central role in shaping their decisions about prescribed psychiatric medication. This sense of coping being framed very much by their personal experiences, social stresses, significant life events, what's happening to them in that moment. Can they cope with coming off their medication as well? Is there been some big life event that means that they're struggling more now? And we know that pregnancy is unpredictable, and women come with a whole host of baggage to that very first maternity appointment that forms part of that care bundle that we give to women, and that holistic view of care. And that very much came into play with mental health medication is, can I cope in this moment with having another thing on my plate? In terms of, so it highlighted the importance of adopting a holistic, person-centered approach to treatment planning, and that supports women in exploring how their lived experiences and their emotional responses shape that reasoning within that shared decision-making process. So how does their life experience impact that decision? And then when we look at again, the experiential evidence, women who had personally sadly suffered a poor outcome, such as a miscarriage or stillbirth, it was much harder for them to accept that their prescribed psychiatric medication may not have been the cause. So they almost saw it as, it was that self-blame coming back into it. Well, it must have been the medication. What else could it have been? This responsibility lies on me. I haven't protected my baby because I took this medication. Yet women who were reading or observing that experience as a third party were very much able to see that there isn't that definitive link between prescribed psychiatric medications and that poor outcome. Next slide, please. Sorry. So the findings of this review really highlight the importance of multidisciplinary care and the role midwives play within that. We have a unique relationship with the women that we support that fosters that trust and promotes shared decision making. To better support women under our care, midwives need access to relevant training and resources. This is not something, when I've looked at when I've reflected back on my own training experience, I think I had one session as a student midwife on mental health medications. This is something that I've picked up and learned through experience as a midwife. But actually, we need to be able to understand mental health medications. We need to be able to understand the risks and the benefits, and we need additional training so that we can properly counsel women and give them the information they need. That's where I am. We need to be able to understand their implications in pregnancy and have clear referral pathways for specialist support. So women want to be able to access professionals that have that specialist knowledge. They want to feel like this decision is as important to healthcare professionals as it is to that woman. Discussions around the use of prescribed psychiatric medication during pregnancy, they should be routine. This is something that we should be talking about during antenatal contacts to ensure that we have appropriate care planning in place and we're providing supportive discussions with a known professional where possible. But also thinking about additional training and communication around risk. How do we sensitively talk to women about risk? How do we navigate those discussions about, yes, there is some evidence that suggests that babies may suffer withdrawal from medications. How do we talk about that sensitively with women without that overshadowing negative harm and risk, and understand that from that woman's point of view of and considering as midwives that there is going to be an element here of that maternal role of I need to protect my baby. And how can we help midwives to engage sensitively with women's lived experiences while reducing stigma and promoting that informed and individualised care? But it's not just about midwives. We heard at the beginning that GPs routinely report a low confidence in counselling women. So how can we educate our other healthcare professionals? How can we ensure that women are getting consistent information so they're not feeling that they've been told one thing by one professional and then another thing by another professional? Because that, again, it creates that mistrust and that it leads women to look at other avenues. Well, if the professionals don't even understand it, how am I meant to understand it? Next slide. Oh, and it's probably worth saying as well that this is about bringing professionals together too. This isn't just a midwife's role. This isn't just a mental health role. This isn't just a GP role. It's about working together as a multidisciplinary team and kind of bridging that gap between maternity and mental health services to improve outcomes for mums and babies. So the literature review also highlighted a gap in the current understanding of the influences on women's decisions. The majority of the research available was over 5 years old. The experiences of women and birthing people from backgrounds of social deprivation and our global majority women were underrepresented. Yet the statistics show that these women are at a much higher risk of suicide than any other subgroups. So I'm in the process of completing my primary research study, and that really aims to address these gaps and provide a contemporary picture of the influences on women's decision-making regarding prescribed psychiatric medication in pregnancy. So I've had ethics approval via Bournemouth University, and have worked with a lived experience group to support the development of research questions and how to recruit specific subgroups of women. So the PPIE group that I've worked with were a group that was set up to support women who have suffered with addiction, been victims of domestic violence, have struggled with mental health, have backgrounds of, as I said, substance and alcohol dependency, and that have quite complex social risk factors and have navigated pregnancy and have had experiences of mental health support in pregnancy. And it was a really lovely group to be a part of. So I initially started out actually before my research was even an idea, just as a volunteer with the group, and kind of offering that, bridging that gap between women accessing services, health services, with women who routinely sometimes don't engage with services, and trying to build relationships with these women. And then my research was actually quite separate. And I was talking to the founder of the group one day about my research. Who said, do you know what? These women would love to be involved. They would love to talk more about this. So bringing them into it and then feeling like a part of developing something and having a positive influence on care for women, and almost that their experiences, which for a lot of these women were quite poor, and they talked about having quite negative experiences of maternity services and mental health services, to see that there being a positive outcome from that, and professionals being able to learn from that experience was really empowering for me as a researcher and as a clinician. So where am I going next? Next slide. So I used varying recruitment strategies. I recruited via social media. I did some face-to-face recruitment via local mum and baby groups, and very much targeting areas with high populations of diverse cultures and women from various social backgrounds. And then I also linked in with some gatekeepers. So I used a Made for Mums. They are a company that do product reviews for new mums, and they have a specialist group of mums who have signed up to be testers and reviewers for products, and they were really kind in sharing my research poster, so that I would be able to reach a broader kind of diverse population of women. I did find some issues with online recruitment, and it's probably slightly off topic, but something really.
Yes, I'm
Yeah.
sorry, we have just less 10 minutes.
Okay, no problem. Well, let's skip to the next slide then, because what I would really like to share is the a few findings. So I recruited 6 women, all with varying experiences, and they were really open. And the next slide is actually quotes directly from the interviews that I had with women. So next slide. And that's what I really wanted to leave people with, is that this isn't just about medicine. It's about equity, compassion, and informed choice. It's about building a healthcare system that doesn't leave women alone with what feels like an impossible choice. It's about listening, understanding, and responding with care that supports the whole woman. So thank you very much for your time, and I hope you found this interesting. And if you have any questions, I'd love to answer them. Time flew.
Yeah, thank you so much. Thank you so much, Jess. Okay, let me see if had any questions. Sandra Williams said, what's kind of supportive mental health service are providing with moms now at your workplace?
Yeah, so we have a specialist perinatal mental health midwife who works with our perinatal mental health team, and she cares for our moderate to severe women who don't fit the criteria for perinatal mental health. And then we have a mental wellbeing midwife who works with our low moderate women and provides a support group for those women. So they do come together. That peer support is really important, and also looking at antenatal education for those women, because a lot of women who have anxiety around pregnancy just feel that they need a bit more information. They need to know about pregnancy, and they want to feel supported. In terms of that mental health medication side of things, that's something that I would really like to bring in into where I work, and I'm hoping to use my research as a starting foot for that with our maternity services.
Okay, good. She's thanking you. Okay, I have two questions. The
Yeah.
first one, how has your research impacted your practice?
Yeah, I am so much more confident now in talking to women about their mental health because I've been doing it day in, day out, with my research. And women, so I see women quite routinely around 16 weeks, and they're quite shocked at the fact that people are talking to them about it. It's usually just a tick box question. Are you feeling okay? Are you feeling well? Rather than, tell me about your mental health history, tell me about your experiences. And that's almost like people are allowed to talk about it more because somebody wants to know that they're asking that bit deeper rather than just how are you today, and digging that bit deeper. And I think more that's probably what's been the biggest change in my practice is just to dig deeper.
Okay, the second question is, did you find some problems when you interview the women who had mental health issues or disorder, psychological disorder? Did you find some difficulties to connect with them, to do any great communication with them?
Um,
Because from my experience, it's so hard to communicate with women had mental issues or had some psychological disorder, for example, anxiety, depression,
yeah,
phobias.
so the women, as part of my research study, had either a diagnosis of anxiety or depression, or had struggled with their mental health with low mood. So they were what in terms they were kind of that low moderate risk category. And these women were actually really open to talking about their experiences. They really felt that they had either had a really good experience, and most of those women that had had a really good experience was because they came into their maternity care very much knowing this is what I'm going to do. I don't need any information. I've got a plan and I'm going to stick to it. Whereas those women that came into their maternity care thinking, I don't quite know what I want to do, I need some more support, I need some more information, they were the ones that felt that they had a poor experience and didn't get the information they need. And those were the women that wanted to come and talk about it and be like, actually, this isn't good enough. We need to do better. And this is what you could do more. And they really felt empowered to be able to talk about their experience. And again, it comes into giving women a voice in terms of improving care outcomes, and especially those women who wouldn't normally engage in research.
Yeah, thank you so much for your response. Thank
Thank
you
you.
so much. Thank all of you. If you have any questions, we have 5 minutes.